Thank you, Jackie. So one of the questions I get often is, tell me about your community paramedic program at Mayo. And for 13 years, the answer has been, well, we don't have one. But we have one now, and so we're going to hear from a couple of people that are engaged in that project. Dr. Paul Kranz is going to start out, and then Luke Myers will join in a bit.
Well, good afternoon, everyone. Thank you for this opportunity, and thanks to everyone for inviting me for this program. I'm gaining a lot of knowledge and destined to bring this back to improve our program at Mayo. A little background on me. I'm a retired military officer, medical surgeon, and when I left the military in 2008, I found myself in this brand new environment, this civilian system that I saw a lot of people kind of overutilizing. In my first couple of years in Mayo, I would pull my social worker to the side and I said, this is the 8th time this patient has come to the ED in 6 months. Is there some form of process that we can engage these patients in order to keep them out of the ED? Because not only is it cost, they're getting radiated. There was a number of issues, I think, that kind of made me question the healthcare delivery system. And I thought, well, we're Mayo. We should be able to do something. We're patient-centric, and the patient comes first. Fast forward about 2 to 3 years, I was on my way to work, and National Public Radio was talking about a closure of one of our clinics in a north rural area, Prairie Farm. And that day, I happened to attend Chippewa Valley Technical College's presentation of Hennepin Tech's community paramedic program. Quite frankly, I knew nothing about community paramedic programs, and this was an eye-opener for me. I looked across at my paramedic supervisor, coordinator, and I said, this is something that we might want to look at, especially given the services in our northern regions kind of being deleted. And we both got together and discussed this, and we came upon an administrator in a northern critical access hospital that had a rural grant. She wanted to do this, but she had no leverage and no one was really waving the flag. So with her support, we began to accumulate a body of individuals that help us put together a community paramedic kind of rough draft. This involved a number of different agencies within the hospital and the local technical college. Upon presentation to Population Health at Mayo Rochester, I was informed that I was in a long line of individuals that were trying to improve patient outcomes and patient care, everything from clinical pharmacists to nurse practitioners, palliative care, home health. And if we were going to engage this, that we needed some data. And we needed Mayo data that was specific to Mayo, because our organization is somewhat different than other healthcare organizations in how we provide care. So a little frustrated, because I thought we were being assigned an administrator assistant. I left the room with my cohort, and we both went to my office and sat down, and he thought, we can still do this, and made some contacts with individuals at Gold Cross and Mayo Medical Transport, and this idea was enthusiastically brought online, and we began the process of developing our CP program. So this has been about 4 years in the making for me, and probably the last 2 years we've done some pretty intense work with developing our program and fielding it, and that's what we're going to go over today in some of our pilot results. And this is the slide. Is that? Which did that? So this is Barron, Wisconsin, Barron County, Wisconsin. It's in the northwestern region of Wisconsin. We have a critical access hospital there. Roughly serves a population of, I guess we don't have the population, oh, there it is, 45,000, about 890 square miles that our community paramedics cover. Gold Cross Ambulance in Barron, Wisconsin employs 9 full-time advanced care paramedics and gets about 1,500 calls of 911 and interfacility transports. Mayo Clinic in Northland is our critical access hospital. We have about 5 in the region. Eau Claire is the center with a level 2 trauma center, a relatively large hospital, but these critical access hospitals kind of serve and filter and we're the referral center. It is itself a 25-bed critical access hospital with primary care, about 445 employees. So we took a multidisciplinary approach to this. I knew that if we were going to engage this process, that we would have to get buy-in. And that buy-in, I felt, was important not only just for the situational awareness, but also we wanted to make sure that we weren't stepping on anybody's toes. We used myself, emergency department physician leadership, clinical pharmacists we engaged, also healthcare administration, EMS leadership from Gold Cross, and research coordination. We brought nurses in from the go. We did that purposefully just because we knew that they were going to be one of the individuals or groups that may put a barrier to us moving forward. Home health and hospice, Office of Population Health, palliative care, quality resources. We got our own IT representative to help us build our medical record, compliance individuals, and then, of course, local paramedics. So what we did, what Gold Cross was able to accomplish, is we took two community paramedic trained individuals and placed them both half-time. So we basically took one FTE, so one community paramedic FTE, split those between those two individuals and operated. We sat and walked through our medical guidelines. We had a number of meetings where we wrote what our expectations were, and then, of course, appropriated the vehicle and equipment necessary. So the patients that we wanted to engage first, of course, my mantra was these high utilizers, frequent flyers, some would call them. We initially took a poll of the barren area and found that there were about 100 patients in that area that compromised 1,700 ED visits within a year. So we wanted to target these individuals initially. We got in hold of their primary care providers. We actually started out making cold calls, and they weren't really received very well. They didn't know what we were doing. We thought probably we were trying to sell them something. And we found significant assistance when we brought in the primary cares and had them do a referral, sat the patient down and discussed the need and what the community paramedic could do. And we found great acceptance after that. We wanted to get an N of about 20 patients a week. And as we were walking into this process, the first probably couple of weeks, we only had about 7, I think 9, 7, 12, somewhere around there. We knew that we needed to increase our N for the pilot study. So we also looked at readmission risk. And Mayo Clinic has a pretty detailed method by which they gauge readmission risk. And the new health standards in the states under Medicare is if the patient gets readmitted within 72 hours, that patient's care would not be reimbursed. And as of this last year, in October of 2016, it will now be a fine. So there was an emphasis to try to identify these people, and in the medical record in Cerner, as nurses enter variables into this process, the computer generates a readmission risk, and it gives them a score. So we targeted people that had a score of 14 or above, which was the top of the scale, basically, of readmission risk. And we targeted those individuals, and we had great success there, too. What was good is that our community paramedics were actually able to engage family members and the patients in the hospital before they went home. And then the paramedic would set up a time within 24, 48 hours to get to the house to perform med reconciliation, health assessments, risk assessments, and social connections. These people we knew were going to be rolling on and rolling off of our roles because we would get them through that kind of bridge area until other social services or healthcare services could be amassed. And we were still looking for more patients. And one of our regional trauma advisory councils has a fall risk prevention program in our area. And they were having a great deal of difficulty engaging ADRC and other social services for these at-risk patients. They were being identified by EMS. When EMS went into the home, if they noted a few different criteria, they would leave a packet, contact ADRC. ADRC would come out and do assessments in the home and assist with everything from grab bars to moving rugs and other assisted devices. And so we filled that gap for them. We started seeing some of their fall risk patients that weren't getting their ADRC referrals in a timely manner. We went ahead and put together a pretty good orientation for our primary care providers. We sat them down, told them what we could offer as far as our community paramedic visits and how that might fit into the care plan. That was greatly received by all. So initially, we sought out 6 primary care physicians and offered them the paramedic referrals. But now we're getting referrals from all over. And now we're actually getting referrals from ambulance agencies. They're calling up and saying, hey, this patient would probably benefit from a community paramedic visit and referral. So what we do is we have a relatively robust electronic medical record through Cerner, and it is Mayo-wide. So I can go on and see any patient in the Mayo Care Health System, or Mayo Clinic Health System, excuse me, and the paramedics who are Gold Cross are Mayo Medical Transport affiliated, so they have similar access to that medical record. So we created our own scheduling process with one of our administrators, wrote the scheduling process, and the community paramedics basically went to their computer every day and they could see how many visits or new patients had been referred and what the scheduling would look like. Every visit is probably about an hour. There are some that may be a little bit more brief because we started doing different lab tests in the field like INRs for Coumadin checks, but typically about an hour. The paramedics perform a relatively detailed history and physical examination. They review medication compliance, so they'll go through the patient's medications. They'll ask them about taking the medications, any untoward effects. They get kind of primed by our clinical pharmacists so they can speak in an educated way about what to expect from the medication, why it's important to take, and then communicate with that patient in the home. We also have gone in and assisted with setting up their medication planners, and we've actually removed medications that the patient should not be taking. We don't necessarily control them, but we'll take them, identify them, and place them in a cupboard somewhere and say, hey, these aren't the ones you should be taking right now. We do a PEAT scale home health and safety assessment where it takes everything into effect of the number of stairs, rugs, clutter, air conditioning, heat, a lot of different factors, transportation, and we put that on a scale and are able to kind of get a risk assessment done that way. Family members, we have a couple of community paramedics that actually now are seeing both the husband and wife. They felt that the husband saw what was going on with the wife and said, hey, I think I might help benefit from that. But we also reach out to extended family, whether they're in the community or even out of state, to try to create that bond or that connection where sometimes it's difficult in some of these patients. The elderly patients, they kind of get lost and forgotten. Social services, of course, when appropriate, everything from ADRC down the list, we've engaged in the community. So the visit itself is documented in the electronic medical record, and I'll talk a little bit about that in a minute. But basically, we have created our own folder in the medical record, in the EMR, that the community paramedics note is populated to. We worked with IT to develop this format and this template, and basically the community paramedic goes in and populates the information. As soon as they do, it gets immediately put into the patient's folder as a home health visit, and one of the note then gets translated to the primary care provider for signature, and it gets sent to me as the medical director for signature. So we get that almost automatic review process of the patient's clinical visit in agreement. And we also communicate through the EMR in our messaging system. So I come into work and I can see that I have 13 labs from yesterday's visit that closed out when I was gone. I have an obligation to go in and sign those labs. Similarly, with this kind of information sharing, those notes get put right into that primary care provider's cache, and one goes to me. And also, of course, engaging others involved in the care plan. So, without further ado, this is the guy who does all the heavy lifting for us. Luke is going to talk about our pilot results.
Thank you. Okay, so we analyzed these data about 6 months after we started, so the population is not huge. Yeah, so we had 35 patients enrolled in the program. Those patients received a total of 268 visits, ranging from 1 to 33. Most patients had more than one visit, but we saw each instance of the one visit was typically patients that were referred for like home safety assessment or fall prevention. Median age was 77.7 years, and the majority of our patients were female. There we go. So this is the referral by department. We found this kind of interesting because, as Dr. Krantz touched on, when we initially started this, we focused on primary care physicians. And in the end, the emergency department physicians are actually the ones that did most of the referring. And you can see the two on the right side were actually requested by the spouse of the patient. When they did that, they contacted their primary care provider, so those could fall in either bucket. So the referral reasons, and there were many, management of medical condition, and I'll dig into those a little more in a second, was the primary one, and then falls at home safety was the second highest. Dr. Krantz talked about the 72-hour readmission patients. We had 6 of those, and then kind of a slew of other types of patients that I'll talk about. So there were 35 patients, but they weren't all referred at the same time. So some patients had 6 months post-enrollment, some had 2 months post-enrollment. And how we wanted to analyze this is look at the referral reason and how many times that patient had seen a physician, their primary care physician, been to an ED, or had a hospitalization based on that referral reason 6 months before. Wake you up. 6 months before the program, and then 6 months after. So of the 35 patients, only 17 had completed the whole 6 months post. So that's what this table refers to, and I'll walk you through this because it's a little confusing. So if you look at the first row, it'll tell you that reduced frequency of primary care visits. So of those 17 patients, 12 had a decrease in the number of visits that they had. And then the next column talks about the visits before enrollment and then visits after. So those 12 patients, the 17 patients had a total of 32 visits before and then 13 visits after. And that shows you the reduction rate. Second row, emergency department visits, we had 10 patients that had a decrease, so over half, and you can look at the visit numbers. The hospitalizations is a little different because only 4 patients had a hospitalization before. None of the high-risk readmission patients are included in this table because they hadn't completed the 6 months, but I'll talk about them. So only one of the 3 patients had a reduction in hospitalization. So in other words, the other 3 had one before and then had one after. So the medical management of medical conditions, this was the kind of the primary reason in which people were referred. Those are the conditions which we documented as that referral condition. So diabetes and chronic pain had the most prevalent enrollment. The enrollment numbers then, you can see 11 of those patients finished 6 months post-enrollment, and you can see those are the raw numbers of clinic, ED, and hospitalization reductions. Some of the other reasons, falls and home safety. So each patient that was enrolled after a fall had occurred, so they had at least one fall, and then post-enrollment, no patients had an additional fall. So, and then we had some patients that were enrolled for like INR checks and BP checks, and of the INR patients, there were 3 INR patients, and they had a total reduction of 48 INR visits to the hospital. So they'd have to go to basically the local lab to have their INR checked. Instead, we just did it in their home. So the high-risk readmission patients, these were only at about 3 months post-enrollment, but at the time of the analysis, none of the patients had been admitted to the hospital or readmitted to the hospital. So if you look at the 72-hour window, each patient had passed that. Patient experience survey. So I'm a caveat here. This survey was not probably done in the best manner. We don't necessarily see these results as too legitimate because of the way we delivered it. And how we did that is we had the actual community paramedic ask the questions and then document it right in front of the patient. So it's not your best, not the best methodology for delivering a survey. So we don't put too much stake in this. This one, however, interestingly, the referring physician survey, we did this one legitimately. We did an online, anonymous online tool survey and asked the physicians that referred the patients a series of questions. I just put 3 up here. But I want to point out that when we talk to other health systems, or we talk to within our own health system about expanding our program, this is the piece of information they find most valuable. They really care about what the referring physicians think about the program. And the physicians' opinions have been very good. So some of the challenges, as a closing slide, the documentation and care planning. So when we first started this, we wanted the physicians, the referring physicians, to create a care plan to outline the goals of care. So what is it you want us to do? And especially with emergency room physicians, we didn't see the documentation of care planning to occur. So we kind of created our own, and we're kind of in a, I guess we're trying to figure out yet how exactly we want to address that. Outcome measures are tough, and I mean, there's a lot of outcome measures. We focus today primarily on utilizers, but there's clinical outcomes. And the way in which you measure one patient, for instance, a fall prevention patient, is not a way you're going to measure a diabetic patient. So there's a lot of different outcomes, and just to acquire the information we talked about here, you know, it's not easy. It's painstaking, it's manual. There's no way, I mean, eventually, you know, we want to have a system where you can just pull up a dashboard and it'll give you the information that we showed you. So that's something we're still trying to figure out. And then, of course, the financial information, or the financial piece of it's tricky for us. In Wisconsin, there's no state mandated or no standard for reimbursement. So basically, if our system's fairly unsustainable unless the health system will pump in money to help, you know, pay for it in the future. So, questions?
So you're in your first 6 months of this. What are your goals for 12 and 24 months out? Have you set them yet?
So our internal goal is, as Dr. Krantz started out by saying, is we want to have a decent amount of patients enrolled. We want to have similar data to what we have now to present internally so we can expand our program to further you know, regions within our system. So as far as like particular thresholds of percentages of trying to, you know, reduce by 50%, no, we don't have any specific goals.
So you're specific in the one county that Dr. Krantz showed. I guess my question is, how do you plan to push this through Mayo, seeing how they have other large areas of demographics that, as other providers have talked to around the world, might be better suited for community paramedicine as opposed to the rural area?
Yeah, I mean, you know, we chose this because it's a small area and it's kind of an easy way to kind of, you know, lean into it. I think the next step is to use a rural or an urban area. We have, within our health system, we have probably 4 or 5 urban markets that we can try to replicate this in. Dr. Krantz, do you want to add anything to that?
So we do want to expand. Every provider that we've talked to wants this in their community. I'm getting requests weekly from individuals, when is this going to expand? I believe the first goal was to provide this data. The Office of Population Health, again, felt that there are a lot of organizations or parts of the Mayo organization that were targeting these patients, and we needed to show that this system worked. You know, and this program wasn't just the pilot and getting the data, it was also working out the issues, the development of the medical record, working and coordinating with all of the agencies involved. My hope is that it expands. In the state of Wisconsin, it's non-reimbursable at this point. There's legislation that's moving forward in Wisconsin this year that may change that process. But in Minnesota, it's relatively robust, and I know Mayo being based in Minnesota, Gold Cross being based in Minnesota, it's a big thing for them, and the hope is that this will expand. We did a preliminary run, probably 3 or 4 months ago, where we discussed our findings, our preliminary findings with Population Health, because we needed approval to move through Gold Cross, Mayo College of Health Sciences, am I saying that right? And developing our own community paramedic program. So as we started on the Hennepin Tech model, but as we started looking at that, we needed to preload that. So we asked for permission, and they gave us the thumbs up. And I think we're getting pretty much the thumbs up from everybody up the line. It's just presenting our final data and then getting the go-ahead to commit resources. So.
Thanks for sharing. Curious, did you survey your staff? And then what appetite is there amongst your medics for this?
So we have 2 community paramedics. We didn't do a formal survey. No, that's something I think we probably ought to do. You know, just subjectively, they really enjoy the program. I mean, they carry their cell phones around. You know, we give them cell phones, and they have patients calling them when they're at home, not at work. You know, one thing I didn't mention that was interesting was I meant to mention this, but our 911 call volume for this group of patients has actually increased. And what we see amongst that group of patients is that they're mainly non-transported patients. It's a way for them to try to see their community paramedic outside of their scheduled visit time is what we've honestly determined. So it's strange. But yeah, we're getting really good feedback from the paramedics. They really like it.
We perform a weekly huddle on Friday morning. So the whole group gets together and we discuss any issues, any concerns, patient care plans. And again, kind of anecdotally, but certainly no major issues, very appreciative of the opportunity. You know, they work 911 half time and half the other time they work community paramedic. And I think they enjoy their CP time more than they do their 911 time, quite frankly. So.
The 2 spousal referrals, were those with a spouse, like, does that represent a couple that was being cared for by the community paramedics?
So in 2 cases, we went to a patient's home. I believe it was both times, their husbands saw what was going on and said, I think I could benefit from this too. So they spoke to their physician and became referred in. So when they do a visit, they actually visit with both of them at the